topic is on new treatment. It's short, in 20 minutes to do all the stuff on new treatment. So I will start with a few questions. The first question is how we used recently some the techniques which are available for us, and I will give you some clue with the French national survey we published a few years ago. Then we go through a question why we should change and find new treatment, and we'll finish with what is available as new treatment. So in this survey we made 2 years ago now in France on around 2,000 patients, we observed that we use almost for all patients a non-opioid analgesic. But you can see that most of these patients receive paracetamol, half of them receive non-steroidal and other drugs too. 80% of these patients receive opioids. Most of the time they receive subcutaneous morphine, but also PCA, and less frequently other opioids. So the most frequent use of opioid is for morphine. And for anti-hypergenic drug, we discussed about that later this morning, about 10% of the patients will receive ketamine during surgery. The other discovery we made on this survey was that, in fact, in France we have a limited use of regional anesthesia. To give you some clue, there is around 2% of patients with infiltration, which is quite low. Half of the patients going through total knee arthroplasty will receive a peripheral nerve block with continuous infusion. Only a little bit more than 5% of patients going through colectomy will receive an epidural. There is no epidural performed in teaching hospital, which is quite a pity. And the use of nerve block is more popular, but it depends from one team to another. Some believe in regional anesthesia will perform a lot of peripheral nerve block, some won't. So what are the limitations of these treatment? The first limitation is the limitation related to morphine treatment, because there is a limited efficacy on movement, which compromise rehabilitation. There is side effects related to opioid like nausea, vomiting, sedation, urinary retention, and there is also the problem of hyperalgesia intolerance, which is able probably to favor the development of chronic post-surgical pain. The limitations are also related to how we combine analgesics together. In fact, when we combine analgesic, that's a good idea, but the result is not always that good. We have sometimes limited morphine sparing effect and no impact on pain intensity. We have additional side effects related to this combination, and sometimes we have no impact also on hyperalgesia. Concerning organization, once again in the French survey, we observed that protocols are not that common. It means that, for example, in teaching hospital, there is only half of these teaching hospitals with a protocol of pain treatment. Dedicated pain team are rare also in France, about 14% of centers only. And quality insurance program is only 3/4 of centers. So what can be new? First, we have to consider that there is still a long way to go, and acute pain is not at all well treated in our service. So we need some wake-up call on this problem. What we did in France was to propose revised guidelines of the management of pain using recent data and using the result of this national survey to try to improve the situation. What is available in the literature concerning opioid, balance analgesia, anti-hyperalgesic treatment, regional anesthesia, and organization? For opioid, there is some new techniques. Some have been a failure a few years ago, but perhaps will come back, like the PCA with transcutaneous administration of fentanyl, which is one way to develop perhaps further the principle of the auto-administration of opioid. On opioids also, there is other way to administer opioid. One way is to use this technique of slow-release epidural morphine, which is new on one side, but according to me, has quite limitation related to side effects and to the fact that it's not combined with a local anesthetic. The low-dose intrathecal morphine is perhaps more interesting. Advantages are simplicity, duration of effect, of course, The limitations are related to respiratory depression, and the recommendation is to use only very low dose, around 100 micrograms in a healthy patient, to be able to send back this patient in surgical ward without intensive care unit. Some new drugs are approaching, like the Pantadol, which is close to Tramadol, is double mechanism of action, combining new opioid agonist and also serotonin modulation. The Pantadol may be useful to implement as an opioid therapy. Oxycodone, for example, is not used presently in France, and it's been used for some years in other countries, with some effect and some interesting comparison in this study to placebo, of course, but also to morphine, with some efficacy comparable to morphine and perhaps some additional efficacy in some patients. Concerning the balance analgesia and how you have to combine opioid with non-opioid analgesic, the best choice is certainly non-steroidal. Of course, there are side effects related to non-steroidal, but in this study of Marais, published a few years ago, it clearly showed that non-steroidal was able to reduce the amount of morphine. And one clue is that when you spare 10 milligrams of morphine every day, you spare 9% of incidence of nausea and 3% of incidence of vomiting. So it's quite helpful both on efficacy and also on tolerance of opioid treatment. The second idea is that to combine non-opioid analgesic together, like paracetamol and non-steroidal, is also useful as a first step analgesic. It's been analyzed in this review by Ong recently, showing that at least when non-steroidal is combined with paracetamol, in 85% of the studies analyzed, there was an increased efficacy and there was an increased morphine-sparing effect. So to combine these two drugs together is a good idea. Steroid has been used for some years now, but it was difficult to have a clear idea of what is expected when you give steroids. And a recent publication by Glenn has been able to classify both the effect and the relation between dose and effect. To make it short, you see on the lower part of the slide that the low dose below 0.1 milligrams per kilo was not efficient. The high dose of 0.2 milligrams per kilo did not get further efficacy. So the efficacy was in between, and basically the recommendation of this review was to give an optimal dose of 8 milligrams before surgery, since it seems that the pre-op administration gave more efficacy than intra-operative administration. Of course, concerning regional anesthesia, I told you that in France at least we are not that good on performing regional anesthesia, but still there is some evolution in the realization of this regional anesthesia. One way is to propose to the patient to go back home with a peripheral nerve block, like in this picture. You see the smiling guy on the left. There's a very fault-sided nerve block, a non-smiling girl on the right, who has an infraglavicular block for elbow surgery. So it's getting to the point that painful surgery may be able to go back home earlier than before with this kind of technique. Another way to improve regional anesthesia is perhaps to make it simpler. As I told you, in France we are very bad in performing epidural anesthesia. That's a pity, but that's the fact. And a colleague of mine has tried to develop another technique concerning analgesia with local anesthetic in major abdominal surgery. And he published this study in anesthesiology recently, showing that with a continuous infusion of a pre-peritoneal catheter, he was able to improve analgesia, to spare morphine, and to reduce also ileocean hospital stay. There is still debate about this technique, but still it's interesting to see that you can be effective with very simple peripheral techniques. To go further on this approach of peripheral analgesic, I wanted to also emphasize the future, perhaps, of some peripheral analgesic, like the local anesthetic with a special formulation, slow-release formulation, like the lactic acid polymer or liposome. We've been talking about this technique for years now. mainly in animal, but I hope that shortly we may have these drugs available for a patient. Another formulation of long-acting peripheral analgesic has been tested also recently in animals, was a non-steroidal gelatin hydrogel, which was able to offer some long-duration analgesia. I will be short on ketamine because I think one of my colleagues will describe that further on. But I wanted to give you some clear ideas about that. The recommendation concerning ketamine are mainly intraoperative ketamine, 0.15 to 0.5 milligrams per kilo, perhaps with a continuous infusion for long duration surgery. It's efficient on acute pain and perhaps in some cases on chronic pain. It's a good tolerance with some positive impact on function. What we know is that beyond 30 milligrams a day, we don't get any further analgesic efficacy. It can be used also after surgery, but this time as a rescue, either in a recovery room or in surgery when patients have tried all the other techniques are still painful. It's certainly efficient in many types of surgery, but it seems that best indications are concerning patients with pre-op pain, pre-op opioid use, and intense postoperative pain. Concerning gabapentin and pregabalin, I will make it short too. We have data in the literature showing that a dose of 1200 milligrams before surgery is efficient but is responsible for increased sedation, which is a problem, at least for ambulatory surgery. Efficacy seems to appear as soon as you give 600 milligrams before surgery, with an efficacy on acute pain and possible prevention of chronic pain, but that's not for sure. The pregabalin is around, has been tested between 50 and 150 milligrams before surgery, with some limited efficacy on acute pain, and a recent meta-analysis has suggested some efficacy on chronic pain. We've tried with a colleague of mine, Valerie Martinez, to test the efficacy of combining pregabalin and ketamine in total hepatoplasty patient with a 6 months follow-up. And basically, we didn't find a very interesting effect of this combination. We have a slight increase in morphine-sparing effect. We have hyperalgesia measured by quantitative analysis, reduced only by ketamine, but no impact on acute, chronic, or opioid-related side effects. So combining these two drugs, at least in our hands, was not very useful. Other family of analgesic has been tried over the past year, like alpha-2 antagonist, and clonidine and dexmedetomidine has been reviewed recently in anesthesiology, and there is some on more than 1,500 patients, some impact on morphine-sparing effect, decreased pain intensity. That's the good side. But the bad side is always the same with this class of analgesic, which is hypotension. You see one patient every 9 during surgery, one patient every 20 after surgery, and bradycardia with dexmedetomidine, one patient every 3, which will receive this drug. So it's always difficult to make clear recommendations since efficacy is there, but side effects also. Lidocaine has been tested IV in visceral surgery, and once again, in quantitative analysis, it's possible to show some efficacy, like a reduction in pain score, reduction of incidence of nausea, reduction of the duration of ileus and duration of stay, only in visceral surgery. Since in orthopedic surgery, in fact, our team tested this drug and it was not helpful at all. But the problem, once again, is the bad side of the drug. We have few data on large groups of patients receiving this drug and on the problem of toxicity. Nitrous oxide is quite an old drug, but it's been revisited recently by a group working on Enigma study. And their good idea was this time to follow one part of this Enigma study in Hong Kong. After major surgery, they made a phone interview 3 months after surgery, and they were able to show that in fact nitrous oxide was able to reduce quite importantly the incidence and the severity of chronic pain after surgery. So possibly that's one positive aspect of this drug. I will finish just on 2 slides concerning organization and strategy. The first aspect is how you can use procedure-specific recommendation. I've been working for the last 3 years in this group of PAINOUT, which is a European Union-funded project concerning comparison of process and outcome in patient in European countries. And if you go on this website, PAINOUT.eu, you will find some knowledge library we are trying to develop, which is able to give very simple procedure-specific recommendation on the treatment of pain. And Prospect has been doing that for years, but this project was funded by Pfizer. And the last slide is always on the quality improvement and this interesting idea of benchmarking, how we can compare to each other and how we can learn from each other concerning process and outcome. And in this project of PAINOUT, we've been now comparing our process and outcome in 14 different countries in Europe. And there is a new project going on this idea. It's an international pain registry, which is a chapter by IASP, and also a recent project on, supported by the European Society of Anesthesiology on chronic pain, and some of my colleagues in the room are participating to this project. So in conclusion, I will insist first on organization and strategy. I think that surgery-based protocol has a good idea to improve the way we treat patients. Quality improvement, and perhaps the interesting idea of benchmarking is also one way to improve. Concerning drugs, we certainly have to combine drugs together, but possibly anti-hyperalgesic with non-opioid analgesic should be associated. The priority for non-opioid analgesic goes to non-steroidal, pre-op gabapentin for the meantime, and intra-op ketamine. And altogether, we hope we can perhaps reduce and have to reduce acute and chronic pain. Thank you for your attention.